Perfect. So today we have with us Dr. Ellen Warner. Ellen is a medical oncologist at the Odette Cancer Center of Sunnybrook Health Sciences Center and a professor of medicine at the University of Toronto. Her main research interests are identification and screening of high-risk women, management of breast cancer in very young women, and lifestyle factors that affect breast cancer recurrence and/or quality of life. And Ellen, if I could have you, perfect. So Dr. Warner's research has led to the establishment of the Ontario Breast Screening Program's high-risk program that offers annual MRI and mammography to women across Ontario at a very high risk for developing breast cancer. So I'm very pleased to have Dr. Ellen Warner with us today to share her expertise with our Wellspring community, and I will pass it over to her for the rest of our presentation today.
Thank you so much. Good afternoon, everybody. I just have to figure out how to get these slides to advance now. We were doing fine.
We might have to just click on the screen and then you might click next. It might kind of reset it or prompt it to.
Sorry, what should I click on?
If you just click on the screen, it might just, I guess, activate it and then click the next button. There we go.
All right, hopefully that'll keep working.
Perfect.
So the biggest challenge in putting this talk together was trying to pack all the many advances in breast cancer that have happened in the last few years into a 45-minute talk. So I'm going to try my best. So I have to talk about prevention. This is a disease that's the commonest cancer in women now all over the world. It used to be relatively uncommon in the third world, not anymore. In Canada, 1 in 8 women will get it over her lifetime. That's 12.5%. And even though most of these women will be cured, any breast cancer, the best breast cancer, is the one that never develops. I'm also going to talk about treatment advances. First, metastatic disease, and that's because most of the new treatments that look promising are first tried out in women with metastatic disease. And then if the new treatment seems active and well tolerated, we often advance it to the early stage setting where the goal then is to actually try to increase cure rates, as you'll see. So what's the difference between prevention and risk reduction? Prevention is for groups. If we give 1 million people a COVID vaccine, we know we've prevented a lot of cases of COVID. But for any individual in that group, we can't guarantee that we've actually prevented COVID because maybe they wouldn't have gotten it even without the vaccine, and maybe even with the vaccine, they'll still get the disease. What we can tell each individual is that we've greatly reduced the risk of getting it. So the easiest way to reduce any disease is to avoid the risk factors for it. But that's not always possible. As you've seen in COVID, you can't socially distance all the time. And even then, it doesn't always work. So you often need active interventions, drugs, vaccines, or surgery. So when it comes to breast cancer risk reduction, what are some of the risk factors we can avoid? Well, unfortunately, the major breast cancer risk factors are completely unavoidable. We can't help being women. We have 100 times the risk of breast cancer of men. And we unfortunately can't help aging. A 70-year-old woman has 10 times the risk of getting breast cancer over the next year as a 30-year-old. Genetics, we can't pick our families, we know that. And we're finding more and more women who have inherited genetic abnormalities that greatly, or at least substantially, increase the risk of breast cancer. And although we used to only test for BRCA1 and BRCA2, now when we offer women genetic testing, we have a whole panel of genes, right now it's about 19 of them, that variably increase the risk of breast cancer and sometimes other cancers as well. We're also offering genetic testing to a lot more women. We used to automatically test every woman diagnosed with breast cancer under the age of 35, even if she had no family history. And we would find genetic abnormalities in about 1/4 of those women. Well, that has now changed. We're now testing all women diagnosed under age 45. We're also testing all women with triple-negative breast cancer under the age of 60. And of course, once we find a mutation, we can offer testing to all the blood relatives of that woman. Even if no mutation is found, having a strong family history is also an important but unavoidable risk factor. Chest radiation before age 30, for example, for Hodgkin's, big risk increase. Having had a previous breast cancer, if one still has breasts, is at increased risk, though not hugely so if these other factors aren't involved. Having had a previous biopsy for a premalignant lesion, such as atypical hyperplasia or lobular carcinoma in situ, again increases risk. Having very dense breasts on a mammogram, again, nothing we can do about that. It's largely a genetic thing. And there are a lot of menstrual and reproductive factors. We can't control when our periods start, how long they last. And although theoretically we could all try to have lots of children from an early age and breastfeed them all, that's not necessarily feasible or desirable for most women. There are a few we can avoid. We can avoid taking hormone replacement therapy after age 50, although there are some women who have such horrendous menopausal symptoms that they need it, but should try to get it for as short a period of time and as low a dose as possible. But there are also lifestyle factors. Each in themselves only raise risk a little bit, but if you follow a totally healthy lifestyle, it can significantly, if you add them all up, reduce one's risk. So we used to say smoking didn't affect breast cancer risk, even though it affected the risk of all other cancers. Well, new research shows smoking is an important risk factor, particularly if it's at a young age before one has a first full-term pregnancy. Huge problem in Europe where women smoke and don't have a lot of babies. Alcohol, there's actually a direct relationship between the amount of alcohol a woman consumes and her breast cancer risk. That doesn't mean we have to abstain, but 1 or fewer drinks per day and not every day is recommended. Exercise, fortunately, it's not a linear relationship. So it doesn't mean if you want to maximally decrease your risk, you have to exercise like as a marathon runner. There's just a minimum threshold, and if you exceed that, it's healthier, but it doesn't necessarily affect your breast cancer risk. If women do moderate exercise, which could be just brisk walking, half an hour a day, 5 days a week, they've maximally decreased their breast cancer risk from an exercise point of view. And it's important to not gain weight after menopause. So as you've seen, we can't do a lot to reduce risk, particularly if a woman has some of the higher risk factors. And therefore, we need to be able to do some active interventions. And for breast cancer, where we don't yet have vaccines, but there's a lot of research on it, and surgery is really only appropriate for the highest risk women, such as BRCA mutation carriers, we're stuck with drugs. Well, who needs it? How do we decide which women should get drugs to reduce their risk of breast cancer? And we really need to do an individualized risk assessment. Some family doctors know how to do this, but generally these things are done at high-risk clinics or genetics clinics where the personnel are trained to do this. And women will be usually referred to this if they have a significant family history or have had a premalignant lesion on biopsy. There are computer programs where you can input all the different reproductive things and various family history and other risk factors and come up with a personalized risk assessment. They give you a lifetime risk, and that's important because women with a 25% or higher lifetime risk of breast cancer should be getting screened, not just with mammography, but with MRI, and starting not at age 50, but at age 30. They should get mammography as well, though, with it. We also, these programs will also give a 5-year risk, and that's important because a woman who has a 5-year risk of breast cancer of 3% or higher should consider something called chemoprevention, which is a ridiculous name because it doesn't involve chemotherapy. It simply means a drug to lower one's risk of breast cancer. So all the drugs that we have to lower breast cancer risk work on the following principle, that the great majority of breast cancers and premalignant lesions are driven by the natural female hormone estrogen. And these cells have little receptors on the outside, these little proteins called estrogen receptors, which are activated by estrogen circulating in the blood. And these activated receptors go into the nucleus of the cell and turn on cell growth and replication, which of course is how tumors grow and divide. To interrupt this process, we either need to lower the amount of estrogen significantly or block this receptor. And we actually use both strategies, not only in cancer prevention, but as you'll see also in cancer treatment. And that's called hormone therapy. So it's a better term than chemoprevention. So chemoprevention is anti-estrogen drugs that are effective. And in fact, they can lower breast cancer risk by approximately 50%. The drugs that have worked are tamoxifen and raloxifene that block the estrogen receptor, and aromatase inhibitors that greatly reduce the amount of estrogen in postmenopausal women. only tamoxifen works to reduce breast cancer risk in premenopausal women, and that's because they have so much estrogen produced by the ovaries that they overcome the effects of these other drugs. In all the studies, treatment was given for 5 years, but the good news is that there was prevention or at least risk reduction of breast cancer, not only in the first 5 years, but also in the next 5 years. Unfortunately, there was no effect on the estrogen receptor negative cancers. That's the minority of the cancers, but they sometimes are the more aggressive. So we're still looking for things that will work on these. The greatest benefit of chemoprevention is for women who've had pre-malignant biopsies like the atypical hyperplasia. They seem to have about an 80% breast cancer risk reduction with taking these drugs. Unfortunately, none of the studies were set up to show whether these drugs actually improve survival or whether they simply prevent cancers that would have been cured anyways. But many women would still prefer to not get a breast cancer. The problem with these drugs is their side effects. Tamoxifen has lots of common side effects. Hot flashes can be bad, vaginal discharge, and so forth, nausea. And there are also some rare but serious side effects. It can cause uterine cancer in about 1% of women. It can cause blood clots, severe depression, and cataracts. And young women who are of childbearing age have to be careful to not take this unless they're on extremely good birth control. Raloxifene, a cousin of tamoxifen, doesn't cause uterine cancer, causes fewer blood clots, but it's less effective and doesn't work in premenopausal women. Aromatase inhibitors can cause a lot of joint and muscle aches, and this may make women less motivated to exercise, which would be really counterproductive. It can thin out bone density, increase cholesterol, and cause really bad vaginal dryness. Not surprisingly, only about 10 to 15% of women who are eligible for chemoprevention actually choose to take it. And that's because if you actually do the math, only 2 to 3% are actually going to benefit in terms of having breast cancers prevented. The side effects I've showed you, and they don't want to suffer with side effects for no known survival benefit. And that's why this recent study is so interesting, and it's been nicknamed the BabyTAM study. So these are high-risk women, age 75 or younger, who had DCIS, ductal carcinoma in situ, which is a pre-invasive form of breast cancer, or a pre-malignant lesion, LCIS, or atypical hyperplasia. And they were randomized to either get 3 years, not 5 years, of tamoxifen, but at a dose, 5 milligrams, that's 1/4 of the standard dose that was used in the other studies, or that's used to treat breast cancer for that matter, or to a placebo. They were followed for an average of 5 years. And interestingly, in spite of this really tiny baby dose, these women in the tamoxifen group had half the number of breast cancers as women in the placebo group. They did have more hot flashes, but not a whole lot more. There was only 1 extra case of uterine cancer. We would have expected 5 with a higher dose. And then percentage with blood clots was identical. Now, one interesting statistic is what percentage of the women actually took their drug for the full 3 years. And in fact, on the tamoxifen arm, almost 40% of the women stopped at some point, which would make you think, well, this probably still had a lot more side effects than Dr. Warner's telling us about. But if you look at the placebo group, almost the same number of women stopped their drug, which shows you how powerful the nocebo effect is. Nocebo effect means women attributing new symptoms to a new drug that they're taking rather than to some other factor. So this is a very interesting drug, and this is something we can certainly offer higher risk women. Onward, let's look at treatment of metastatic disease. So our goal here, although we cure a tiny percentage of these women, perhaps, or probably, for the great majority, the goal is to prolong their survival while maintaining good quality of life. And in treating breast cancer, it's useful to divide it into 3 subtypes based on tests that the pathologist routinely does on biopsies. There's the group that are estrogen receptor positive and negative for a protein called HER2 that can be overexpressed, like it appears in a lot more concentration in certain breast cancers. 75% of women with breast cancer are in this group. Then there are patients who have HER2 overexpression. We call those HER2 positive. That's about 15%. They can be estrogen receptor positive or negative. And then there's the triple negative subgroup. They're estrogen receptor negative and HER2 negative. Well, why do we call it triple? Because they're also progesterone receptor negative. And put that like in sort of tiny font, because actually almost everybody who's estrogen receptor negative is also progesterone receptor negative, because you need a functioning estrogen receptor to make the progesterone receptor. It doesn't really affect our treatment, but that's how we got the name. That's only about 10% of patients. Let's start with the largest group, the ER positive, HER2 negative group. So about a quarter of these women will actually have metastases at the time of diagnosis of the metastatic patients. Not of everybody, most of them don't. But the other group with metastatic disease in the subgroup develop metastases months, years, or even decades after their original breast cancer was diagnosed. And that's a really scary and thing that a lot of women don't expect. But these late recurrences are actually classically very common here. I once saw a woman who relapsed 40 years after her original tumor was diagnosed. Now that's super rare, and the chance of recurrence goes down with each year, but not impossible. It's also sometimes in these patients, when they metastasize, the estrogen receptor flips to being negative, and the HER2 flips to being positive. And that can occur in up to 20% of patients. So it's useful to consider biopsying these patients if it can be done easily, and if, especially if the behavior of the tumor seems a bit odd. And we will retest them for ER HER2, and that will have treatment implications. In these women, in general, it's preferable to start with hormonal therapy, which is really my code for anti-estrogen therapy. It's not we're giving hormones, we're actually taking them away. And that's preferable to chemo unless the woman has life-threatening disease and needs a very quick response. Our first line is usually aromatase inhibitors in postmenopausal women. In premenopausal women, we also generally start with aromatase inhibitors, but have to either remove the ovaries or suppress them with a injection that's given usually monthly. Tamoxifen, sometimes we use, especially if the woman progressed well on an aromatase inhibitor. And fulvestrant or Faslodex is also an estrogen receptor blocker, like tamoxifen, but instead of being an oral pill, it's given as an injection into each butt cheek once a month, which is literally a pain in the butt, and most women would rather get a pill if they can. And that used to be our standard of care, simply slap women on one of these, but that has now changed. And that's because of the discovery of CDK4/6 inhibitors. So this looks like a really busy slide, but just think back to high school biology. This is your classic cell cycle, and cells have a choice. They can either go into retirement for a while, what we call G0, where they're not actively dividing, or they can start actively dividing, synthesize DNA, mitosis, and goes on, and this is how tumors grow. Now this decision, do I go for a sabbatical or do I keep dividing, is controlled by a complex of proteins called CDK4 and 6. And we've now found that a lot of these ER positive, HER2 negative patients have overexpression of this CDK4/6 that drives these cells to keep dividing. If we block this, we can block cell division and make tumors either shrink or at least stop growing. And we now have 3 CDK4/6 inhibitors on the market: palbociclib, which you might know as Ibrance, ribociclib or Kisqali, and abemaciclib or Verzenio. So it turns out in studies that if you add any of these CDK4/6 inhibitors to standard hormonal therapy, you actually double the response duration. So if you're giving them to someone with newly diagnosed metastatic disease, the average duration of response goes from 1 year to 2 years. Now that's average. Some women will actually respond for much longer. And these drugs don't have bad side effects from the patient's point of view. A low white blood cell count, it doesn't usually cause infection and the woman doesn't notice it. Can cause some fatigue and will adjust the dose. They also have some individual quirky side effects. Abemaciclib tends to cause diarrhea. Ribociclib can cause electrocardiogram abnormalities and abnormal liver function tests. And because we like to avoid these quirky side effects, most of us have been preferring palbociclib as our first choice. However, there's some recent studies suggesting that if you give ribociclib rather than palbociclib, it is possible that there's a survival benefit. And in some studies, there's been up to a 1-year survival benefit overall to patients who got first-line ribociclib even if once that stopped working, they got many, many other treatments. Not clear if that's just a statistical fluke that the company that makes ribociclib got lucky about, differences in the patient populations in the studies, or a true benefit of ribociclib over its competitors. And we need more studies to determine that. So what do we do when patients stop responding to their CDK4/6 inhibitor and their first-line hormone? Well, there are often several other lines of hormone therapy that might be effective, but eventually most patients will need chemotherapy. And they often, when we tell them that, they sort of like they turn white and they go, oh my God, I got chemotherapy before and it was a nightmare. I can't do that again. But we're not going for cure here, because even if we gave the highest possible doses of chemo and with the maximum number of drugs, we wouldn't be able to cure breast cancer at this point. So it's best to simply give single agent drugs in the lowest possible dose that's effective, one at a time, and patients can maintain a really good quality of life for a long time this way. I almost never run out of options because there's so many active drugs for breast cancer. But eventually it becomes sort of diminishing returns, and generally women will say, you know what, I've had it. This chemo isn't working or not working for long enough. I've had it, I want to stop. But that could be many years after. And in fact, the average survival now of patients with ER-positive, HER2-negative metastatic breast cancer is more than 5 years, which is incredible. When I went into practice, it was about 2 years. And many women live much longer, like 50% of them do. I have lots of women in my practice who are 10 years plus out and doing fine, playing tennis, working full-time, and so forth. So let's switch to our next subgroup. These are the HER2-positive patients. So normal cells and most breast cancer cells have some HER2 proteins on their outside, but the HER2-positive breast cancer cells have lots and lots of HER2, and HER2 drives cell division and cell replication and tumor growth. And even if these patients are ER-positive, it's the HER2 effect that seems to dominate, and we have to treat that. So there are two monoclonal antibodies. These are intravenous drugs that block the action of HER2. One of them is called Trastuzumab. You may know it as Herceptin, which is the trade name, but we now have lots of biosimilars, so we tend to use Trastuzumab. And there's also Pertuzumab. These drugs are not terribly active on their own, but if you add them to chemo, wow, you get a much, much greater effect than if you only gave chemo alone, and an important prolongation of survival. And if you add in Pertuzumab to the Trastuzumab, you even get a better effect, more tumor shrinkage and prolonged survival. And in this study, where patients got Trastuzumab and chemotherapy and were randomized to either placebo or to Pertuzumab, the response duration was much longer in the Pertuzumab arm, and the overall survival was more than a year longer. And even at 8 years, more than a third of the patients in the Pertuzumab arm were still alive. And this is extremely exciting and impressive. And this has now become our go-to first-line treatment for patients with HER2-positive disease who develop metastases or are diagnosed with breast cancer on already having metastases. It also is well tolerated. There's mild diarrhea for some women. And what we can also do is we don't have to keep giving this chemo forever and ever. We can stop it after 4 to 6 months and simply keep the women on maintenance Trastuzumab, Pertuzumab, and they can do extremely well for years. If they're ER-positive, we usually add in a hormone to this mix. So what do we do though when that stops working? So it turns out that with HER2-positive disease, the response to the next line of therapy is always better if you keep giving the Trastuzumab, like a basic HER2 blocker. Continuing the Pertuzumab doesn't seem to be effective, and our current second-line treatment is a drug called TDM1 or Kadcyla. Now, TDM1 is one of the first of a new and growing class of drugs called antibody-drug conjugates. And these are the ultimate smart bomb. And the way they work is you take a very potent chemotherapy drug that if you gave intravenously would be horrendously toxic to the patient because it would go randomly to all the parts of the body. But instead, you link it to Trastuzumab, which navigates this chemo directly to HER2-positive breast cancer cells, where it can then do its thing and kill cells, leaving the rest of the body relatively spared. Pretty exciting, right? But there's an even better drug now, or at least a more potent drug called Trastuzumab deruxtecan. And here we seem to have a more potent chemo drug attached to the antibody, but also a lot more of these chemo drugs are attached. And that seems to make it much more effective. And in a randomized trial, where in the second line, we were treating HER2-positive metastatic breast cancer, the response rate to this TDXD was twice what it was to the Kadcyla or TDM1. At 1 year, there were more than twice as many women in this arm whose tumor had not progressed, and survival was significantly longer as well. Should this be our go-to instead of Kadcyla? Well, like anything, there's a bit of a catch to it. This drug can cause diarrhea, which we rarely see with Kadcyla. It can cause lower blood cell counts, but most significantly, it can cause interstitial lung disease, or also known as pneumonitis. And in the studies, 15% of patients treated with this drug got this side effect. In the early studies, patients were dying of it, but in the more recent studies, this was being recognized early and patients were not dying. And then it responded to steroids and got the lungs better. However, it is unsafe to re-challenge women once they've had this complication. And it scares us doctors and patients a bit, but it's still an extremely active drug. And it's now available on a compassionate basis. But what about when you're on this, if you progress on the second line? Well, we have third line drugs as well. And these are oral drugs that inhibit HER2. Some examples are Lapatinib, Neratinib, Tucatinib. They're not as potent as Trastuzumab, and their main toxicity is diarrhea. They work best if you combine them with Trastuzumab and with an oral chemo agent such as capecitabine. What's really important about these drugs is they go into the brain, and they can treat cancers, or they can at least prevent brain cancers from forming. And unfortunately, HER2-positive disease, when it's metastatic, has a strong tendency to go to the brain. And Trastuzumab and Pertuzumab don't, and most chemo drugs don't penetrate the brain very well to prevent metastases. These drugs are generally safe for third line. They're not currently funded in Ontario, but they are available in compassionate programs or through patients' private drug plans. The most exciting of these drugs is Tucatinib. And in a recent trial, patients were randomized to get Trastuzumab and the oral chemo capecitabine with either Tucatinib or placebo. And in the Tucatinib arm, they responded for longer and survival was better. And it's particularly striking what happened to the patients who had brain metastases. They not only went a longer time before the disease progressed in their brain, but at 1 year, whereas in the placebo arm, every single patient had brain mets that had progressed, new ones or the growth of old ones. There was 40% of patients in the Tucatinib arm had not progressed, and this drug is probably going to be pushed up to earlier lines, possibly even to the adjuvant or curative setting. Okay, moving on to our last subgroup, the ER-negative, HER2-negative, the triple-negative breast cancer patients. This is really a grab bag of diseases if you look at a molecular level, and they behave differently. They're not all the terribly aggressive cancers that triple-negative is notorious for. Most of these patients recur early, unlike the ER-positive patients, within the first 3 years. And until recently, the only treatment we had for metastatic triple-negative breast cancer was standard chemo, and the average survival was only 12 months, which is, compared to the 5 years for the other subtypes, very discouraging. But we do have some advances. And one is the recognition that some of these patients are hormone sensitive, not to female hormones, but to male hormones called androgens. Up to a third of these women have that kind of drug of disease, and it's most common in the apocrine subtype. These breast cancers tend to have a slower growth than some of the other triple-negative breast cancers, and up to a third who have the androgen receptor, will respond to a male hormone antagonist, such as bicalutamide, that's very commonly used to treat prostate cancer, and it's well tolerated. Here is a brand new drug, another one of these antibody drug conjugates. And here, the target is not HER2, because these patients don't have HER2. It's a protein called TROP2 that is expressed in 90% of triple-negative breast cancer. And in a study in which this new drug was compared to the physician's choice of a single-agent chemotherapy drug, This is for patients who already had 2 lines of treatment for metastatic triple-negative breast cancer. The average survival was much longer. It doesn't look like a whole lot of months, but when it's the average response duration was 4 times as much, and the average survival was almost 6 months longer, which in a disease with such generally short survival, especially after 2 lines of treatment, this is incredibly exciting. And this drug is now available on a compassionate basis. It is also fairly well tolerated. Low blood counts, diarrhea are the main side effects. Well, one of the questions I get asked the most by patients is, what about immunotherapy? Because of course, immunotherapy has been this breakthrough therapy that's dramatically changed the natural history of many, many cancers, such as melanoma, kidney cancer, lung cancer, and so forth. Well, unfortunately, a lot of the early studies in breast cancer were a bust. It didn't seem to have any effect. And it still looks like if you give immunotherapy on its own, it doesn't work. But it seems that of all the metastatic cancers that might respond, triple negative is the most responsive, but you have to give chemo too. And here is a very exciting study. In this study, first-line metastatic triple negative breast cancer, patients were randomized to standard chemo with either the immunotherapy drug pembrolizumab, also known as Keytruda, which is a programmed DEF1 inhibitor for those who are into that, or to placebo. And here are the results. This is not disease-free survival, but actually overall survival. And there was a very significant difference at the 2-year mark. 48% of patients on the immunotherapy arm were still alive, compared to only 34% in the placebo arm. So don't tell me that I'm not giving you hot off the press data. Yesterday, Health Canada approved this drug, and we now have a compassionate program to offer this to our first-line metastatic triple-negative patients, but only the 40% who overexpress this PD-L1 to a significant effect. For the other patients, adding immunotherapy is not effective. So we need to be able to tease out this 40% who would respond. Final subgroup that doesn't really fit into those 3 classifications I gave you is the women with inherited mutations in BRCA1 or BRCA2. And this is actually 10% of patients with triple-negative breast cancer. It's a smaller group in the other subtypes. And BRCA genes, the normal ones, are important to repair cell damage that's constantly happening to cells for reasons we don't really understand, but it's a very efficient repair mechanism called homologous recombination, or HRC. If a woman has a mutation in BRCA1 or 2, she will still have one normal copy of that gene and also a defective copy in every cell, and the cells can still do normal repair of any damage. Their tumors, however, tend to lose the normal gene copy, and they're stuck with no ability to do this efficient homologous recombination, and they have to rely on an alternative, less efficient gene cell repair pathway called PARP. So if you inhibit PARP, that should have very little impact on the normal cells who can repair themselves the normal way, but it should be deadly for tumor cells. And in fact, we have 10 PARP inhibitors that are currently under development just for this. The one that's furthest along in development is called olaparib. It's an oral drug. And in this study, they gave it to over 300 BRCA mutation carriers with metastatic breast cancer who had had up to 2 previous lines of treatment. And they were randomized to olaparib alone, single oral agent, or to some type of single agent chemo. And there was twice the response rate in the olaparib arm compared to the chemo arm. The duration of response was almost twice as much, and there was much less toxicity for the olaparib patients. Unfortunately, the overall survival was the same, and because of that, so far our government doesn't want to fund the drug. It is available, however, to people with private drug plans or people who can access the somewhat difficult to access compassionate program that the drug company has. And I have a couple patients on this really doing well on it. Last thing is brain metastases. Doesn't quite fit into these subgroups either, but it's very common with HER2 positive and triple negative breast cancer. We rarely do surgery for these women. And until recently, the standard of care was to radiate the entire brain over a 2-week period with 10 treatments. It caused a lot of side effects, both early on and also late. But the new standard of care is something called stereotactic radiosurgery, also called Gamma knife. And here we can give very high doses of radiation, precisely targeting the brain tumors only and spare the normal brain. And you only have to give 1 or 2 treatments, and lesions that are up to 3 centimeters can be treated. And there's a growing number that the radiation oncologists are willing to treat. A woman can have 10 brain metastases and they'll all be treated this way. It has few side effects, and if the lesions grow sometime after treatment, they can be retreated. And this has caused tremendous improvement in the quality of life of these women. So let's move on now to invasive local disease. And this is a setting where the goal is cure and hopefully with minimum side effects. So a few definitions. Adjuvant therapy is treatment that we give after the breast cancer surgery to decrease the risk of recurrence, because we know that statistically, a lot of these women have microscopic disease that if we don't treat it at some point in time is going to manifest itself as metastatic disease, distant and from the breast and incurable. There's also neoadjuvant therapy. It's giving the same kind of treatments we would give in the adjuvant setting, but before the surgery. And the goal here, again, is to decrease the risk of recurrence, but also it often enables us to do less extensive surgery. So for example, a woman who would normally need a mastectomy because her tumor is too big for her breast might find that after neoadjuvant therapy, she can have lumpectomy and followed by radiation, so breast conserving therapy. There are also some new reasons to give it though. As you'll see, it can allow us to estimate the risk of recurrence and also guide the need for adjuvant therapy. So they'll get neoadjuvant therapy, surgery, and then further adjuvant therapy if necessary. So again, it's helpful to look at our 3 breast cancer subtypes. And we can now get ER and HER2 testing done routinely at the time of biopsy, which helps us guide what kind of treatment we want to do. Do we want to do neoadjuvant? Yes, no. So again, let's start with our biggest subgroup, the ER positive, HER2 negative patients. And we give these patients neoadjuvant chemo less often. And that's because these tumors are less sensitive to chemotherapy than the other subtypes. The tumor, though it often, even when the treatment is effective, instead of the tumor shrinking concentrically as it does in the other subtypes, it tends to be sort of a random cell dropout. So the overall volume of the tumor is the same amount of breast needs to be taken out, but the actual number of tumor cells may be very, very low. But it doesn't affect the kind of surgery that needs to be done. It's also, the response is less predictive of survival. So in these patients, even at the time of surgery, if we still see active breast cancer cells, because we're going to then give them hormonal therapy, their survival doesn't seem to matter a whole lot, whether there's tumor there or not. And the response won't affect adjuvant treatment. We're still going to give them hormonal therapy, whether the disease is all gone or not. Almost all these patients get adjuvant hormone therapy for 5 to 10 years. So my biggest dilemma as a medical oncologist when I see one of these patients is, do I put this woman after surgery directly on hormone therapy, or do I give her chemotherapy first? I saw a woman like this morning. And what's very helpful for us is these new multigene prognostic tests. There are a whole lot of them. The ones we use most commonly at Sunnybrook are Oncotype DX, which has 21 genes, or Mammaprint that tests 70 genes. And these are all genes that affect breast cancer sensitivity to hormone therapy and invasiveness and risk of recurrence. And you get a score at the end. The tissue is sent from the pathology department to a commercial lab. The results take about 2 weeks to get. And we don't have to send this on all patients. Some patients have such tiny tumors, negative nodes. We know that they only need hormone therapy. And some people have such big tumors or lots and lots of nodes in their axilla, and we know that they need chemo. But these are very helpful for those gray zones where there are very few nodes, low risk features, or women with node negative disease, but some higher risk features of the tumor. And the chemo is only necessary if this score comes back high. So a little bit more ambiguous in premenopausal women, much more clear cut in the postmenopausal women, but always helpful. The cost is covered by our government. And this test can be done on a core biopsy or on a surgical specimen. And this has been incredibly useful during COVID because doing it on the core biopsy meant that we could give people chemo if they needed it while they were waiting for their surgery, which was often delayed. And the results of these tests don't correlate perfectly, so we still don't know which one is best, but they're both very helpful. Adjuvant hormonal therapy is usually given for 5 to 10 years. It's actually more effective than chemo. So if patients only want to get one type of treatment, they should probably opt for the hormone therapy. And the risk of death drops from 30 to 50%. So they're very effective. In postmenopausal women, aromatase inhibitors are really only a little bit better in terms of survival than tamoxifen. So if a woman doesn't tolerate them, tamoxifen is a good choice. And differences are a bit more marked for invasive lobular. For premenopausal women, if the women are higher risk, they should also have their ovaries suppressed to get rid of that ovarian estrogen. We can give tamoxifen or an aromatase inhibitor, not clear which is best. If they're very low risk, tamoxifen alone is much better tolerated because they don't have to go through that premature, though temporary, menopause that's very, very uncomfortable for young women. But the most effective hormone is the one women take. So if we have to be, if women aren't tolerating it, instead of stopping it and not telling their doctor, they should tell their doctor because they can have a different hormone prescribed or maybe a different dose and still get all the benefits. What I get asked the most is how long should the woman take hormonal therapy? And the recommended duration really depends on the risk of recurrence, how well they're tolerating the drugs, and patient preference. To some women, taking a pill every day is really comforting. They feel they're doing something to prevent recurrence. To other women, it's a nightmare because it's a constant reminder that they had breast cancer. Most women ideally need 5 to 7 years of hormonal therapy total. If women aren't going to get an aromatase inhibitor, we know that 10 years of tamoxifen is a little bit better than 5. And no study's ever shown a survival benefit for more than 5 years of an aromatase inhibitor. In the mammoprint test, there's now some women have ultra low risk tumors and they only need 2 years of adjuvant hormone therapy. We generally recommend zoledronic acid to a lot of these women. It's a drug that's commonly given for osteoporosis. It's a short infusion. We give it every 6 months for 3 years. And it not only protects women's bone density, which often suffers from the aromatase inhibitor, but it also increases survival by about 2 to 3 women out of 100 will have be cured of their cancer simply because of their zoledronic acid. And that's only in postmenopausal women. We don't see the survival benefit in premenopausal women. We don't know why. It does have some side effects. Everything has a price. Some women have bad flu-like symptoms, usually worst after the first dose. It can rarely cause kidney failure and can cause some dental problems rarely. So we recommend women have any major dental procedures like extractions or implants before they start this. Well, what about CDK4/6 inhibitors? They're so active in the metastatic setting. Wouldn't they perhaps be active in the curative setting? And of course, everyone thought of this. And that's why we have studies. Every single one of these CDK4/6 inhibitors has been tried in a randomized trial of hormone therapy with or without a CDK4/6 inhibitor to see whether it decreases the risk of recurrence and improves survival. The palbociclib trials have shown no benefit. The ribociclib trial, which gave 3 years of the drug, and the other ones gave 2 years, we don't have results yet. But the abemaciclib trial is positive. And that gave the drug for 2 years to high risk. And these were all for high risk patients. Low risk patients don't need these drugs. They simply add more side effects. In this abemaciclib trial called Monarch E, the 3-year distant disease-free survival was 90.3% in women on abemaciclib compared to 86.1%. And this drug has now been approved in Canada for this indication. And there's a compassionate program that allows our high-risk patients to get abemaciclib with their standard hormone therapy. So what about the HER2 positive subgroup? So for a long time, it was standard to give either adjuvant or neoadjuvant chemotherapy with trastuzumab, usually overlapping the chemo with the taxane arm. And then when the chemo stops, the trastuzumab continues intravenously every 3 weeks for a year. Hormone therapy is added if the patient is ER positive, and no difference in survival in neoadjuvant setting. And if the patient gets a complete pathologic response, that means no tumor left in the breast and no tumor in the underarm nodes, the prognosis is outstanding. But now we're giving most of these patients neoadjuvant chemo. And that's because in a randomized trial of these patients who got neoadjuvant chemo and then surgery who had residual disease, and then were randomized to trastuzumab or to TDM1, there was a significant disease-free survival advantage to the TDM1. So these patients now it's funded here, and they will all get TDM1 instead of Trastuzumab, but only if there's residual disease. If they have a PCR, they don't need it. And triple negative breast cancers, we have almost the same situation now. We used to give neoadjuvant or adjuvant chemo without, much to choose from. And the PCR patients, again, did really, really well. Now, again, it's standard to give most of these women neoadjuvant chemo. And that's because of another randomized trial showing that those with residual disease who got 6 to 8 cycles of the oral chemo capecitabine did significantly better in terms of survival than those without chemo. BRCA mutation carriers, what about olaparib? Good question. So in this study, patients who are high risk, who had germline BRCA 1 or 2 mutations, that means inherited mutations, randomized to placebo or a year of olaparib after their standard chemo or hormones, again, did much better. There was a 3-year overall survival advantage. And this is now licensed by Health Canada and is recommended, although it is not yet funded. Just in the last minute or two, I just have to talk about adjuvant radiation. I'm not a radiation oncologist, but there's been so much amazing progress here. We generally radiate anyone who's had lumpectomy or who's had a mastectomy with high-risk features and positive nodes. But we can now tease out a group of women who maybe don't need radiation. If they're over 70, have small ER-positive, HER2-negative tumors, no axillary lymph nodes, and are getting adjuvant hormone therapy, these women do great without radiation. We also find in the past, we always told women who'd had breast conserving therapy that if they ever got a new cancer in that breast, that we wouldn't be able to offer them radiation again, and they would have to have a mastectomy. Well, that has been changed. And now these women are often candidates for repeat lumpectomy and reirradiation. And we don't have long-term data on these patients, but so far they seem to be doing well with not terrible complications in the breast and not a high recurrence rate. Also, the duration of adjuvant breast radiation. When I was a resident, everybody got 5 weeks of radiation Monday to Friday. And then about 20 years ago, the standard was changed for many patients to only 3.5 weeks. And now new studies show that 1 week, what's called hypofractionation, so you give a higher dose, but only for 5 days, it seems to be safe. And so far, with 5 years of follow-up, it seems to be really effective. And this was used to our advantage during COVID, when nobody wanted to come into the hospital any more often than absolutely necessary. And finally, women who had positive sentinel lymph nodes in their underarm used to have to get an axillary dissection with a 30% risk of arm swelling or lymphedema. That has now been replaced with radiation, which has only a 10% risk of lymphedema. So that's a huge advantage to patients. So finally, I just want to say, patients who only had a few metastases, we used to tell them, well, you have incurable disease, and sorry, we can only palliate you. But there's now a movement to try to treat these women for cure. And the reason we can do that is we can offer stereotactic tumor-killing radiation precisely to these metastases, and we need longer follow-up. But anecdotally, some of these women seem to be doing extremely well, are probably cured, but we need to have randomized trials. So breast cancer mortality has been progressively dropping for the last 30 years, and you can see that with all these new breakthroughs I've told you about, this number is going to keep going down, 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 down. And similarly, the number of cured women is going to go from, it used to be 36% when I went into practice, 20% in 2018, but I bet it's even now down to about 18%. And that green bar is going to keep going up, up, up. And all we need now is to figure out how to prevent breast cancer completely. Thank you.
Thank you very much, Dr. Ellen. That was a very informative presentation, and you covered such great content in such a comprehensive way. So thank you so much for that.